I think I've met most of you, maybe not all, but yeah, I was in Kelly's role for a number of years before, and not at the very beginning of PLP, but close to the beginning, and certainly got to be there when we kind of went from struggling to having almost more work than we can do, and so it was a really fun thing to watch things proceed over a few years. I think we have some disclosure slides. You know this guy. This is Dr. Armson. I don't think really any of us have anything to disclose. So far, no one's paying me to do this work. Here's an outline about what we're going to do. It's a little bit difficult to workshop this in a group of sort of people who have all different roles, so I have to confess it's going to be like an interactive talk more than a workshop. But jump in and interrupt if you've got questions at any point. We're going to start just by a brief kind of historical look at old-fashioned CPD and why we wanted to move towards audit and feedback model. We'll talk briefly about the literature on that and some of the foibles of audit and feedback and why it sometimes doesn't work. And then we'll talk about how we came to arrive at the process that we use now in PLP, and hopefully other people are starting to adopt around the country. So what is CPD for? Why do we do it? So people do it because they're made to, because you can't have your license from the college if you don't do it. People sometimes do it because it's a free trip to somewhere or a tax-deductible trip to somewhere. Ideally, people also do it because they've realized they have a gap in their abilities that they want to fill, or maybe their scope of practice has changed and they have something new that they need to be able to do well. And hopefully the sort of premise for most people is to actually just do it because they want to be a better doctor and take better care of their patients. But there's lots and lots of reasons. COP is having a community of practice. So one of the things that comes out of CPD, if it's well designed, is people are together in the same room who do like things and they share with one another. And you're going to see me say CPD doesn't work, and I'm going to say it in air quotes because I think it does work. The traditional models of CPD, which are lectures, they don't tend to change patient outcomes, and they seldom change physician performance. But there's also other reasons people go, and I think one of them probably is community of practice, because it's an opportunity to connect with someone who has an answer to a question you have, or to a colleague who's kind of walking a similar journey. CPD consists of a lot of different types of experiences and things, and when I was in Kelly's role, we tried hard to offer things that were kind of all around this circle. Some are easier to do than others. Simulation's hard. Audit and feedback is hard. 360 reviews can be hard. You know what's really easy is lectures. You know what's really easy to do as a participant? Lectures, yeah. So this has been the model of CPD forever. People go and they sit in a big room, and many of you will have been there in the big room or else been behind the scenes building the conference that goes on in the big room. But this bums and seats model is really not favored from an educational standpoint, and these days also really not favored from an accreditation standpoint. So why is that? What's wrong with bums and seats? It's a unidirectional sort of passive transfer of information. And we know from excellent literature in knowledge translation, implementation science, and also education that passive transfer of information tends to be rather ineffective in getting someone to do something differently. One of my colleagues, this is a quote from I don't know who, maybe someone in the audience knows, but they talk about a lecture being a phenomenon where information passes from the mouth of the speaker to the nose of the learner without passing through the minds of either.
Yes.
Right, I don't know who said that, someone famous. Bob Lee said it to me, but I don't think it was his. So Dave Davis, who some of you will know of, some of you may have even met him, is a leading thinker in CPD, and he works at the AAMC, unless he's retired now. I don't know if he's still at it. He might have retired. He's Canadian, but worked at the AAMC and published a lot of the seminal papers in CME. And his sort of big thesis was what we've been doing all this time is not very effective. He published a lovely paper in 1999 in JAMA and basically reviewed the outcomes of a huge number of papers reporting on what they did in CME, and essentially said, traditional CME doesn't change anything. That won't be news to a lot of you. There was actually a subsequent paper that came out a few years later in CHEST that said maybe some things do work, but the takeaway point is maybe the old-fashioned way of doing things is not the way we should be doing it going forward. And in fact, Joan Sargent, who works closely with Heather, published a nice paper saying we need to be thinking about knowledge translation more when we're doing education, because what we're talking about in CPD particularly is taking the best evidence and putting it into practice. And a lot of the knowledge translation people have been sitting in the corner of the room going, for a long time because they know that there's a science behind getting people to change their practice. And so that's where we start to think more about things like audit and feedback. So many of you know Jocelyn Lockyer. She had Kelly's job before I had it for many years, and she was one of the sort of founding members of PLP. She and a couple of others went to Alberta Health and said we should do this and got the money. And she published a nice paper back in 2007 looking at the effect size, so how much impact does each type of CPD out there have. And what she showed is things along the lines of audit and feedback are more effective than most other types of CPD. And so that was really what spawned the idea. So this is published in 2007, and PLP was born in 2009. And so you can ask yourself if there was a connection, and I suspect the answer is yes. So we do know that audit and feedback is effective. One of the reasons it has a certain amount of appeal from a CPD standpoint is that it hits the top of our kind of desired outcomes a little bit better than some of the other things. So certainly when we do a lecture or a conference and have a bunch of people sitting around, most of them will say they liked it. Lots of them will say they got something out of it. So participation and satisfaction occur. Sometimes learning occurs. But we don't tend to be able to describe someone's competence or look at their performance in the context of lectures that are given in a big conference hall with all the bums and seats. When we're doing audit and feedback, we're starting to get at the top of the pyramid to some extent, particularly if we do it well. You know, this question comes up. I think most people that are involved with audit and feedback believe it works. That's why we do it. As you all know, it's very hard to work with administrative data and get it back to people and get them engaged with it. It's a lot of work. That's why there's such a big team that does this together. So yes, we think it works, but if you look at this big, beautiful meta-analysis that was published in 2012, what you see is the size or magnitude of the effect is highly variable across these 140-odd studies. And so the question becomes why? And some subsequent papers that came out from the same group asked that question, and they said, you know what, let's just stop publishing studies that say audit and feedback works. We're all convinced. We need to do some more science on this. Let's science it so we can figure out why it sometimes works well and sometimes doesn't. And that's kind of what PLP was in the process of doing, albeit through trial and error from the time we started in 2009, because I can tell you in the beginning we did a lot of projects that didn't work very well. And over time, we got better at it by tweaking all these different things that actually a couple of years later kind of appeared in this Brehout paper about sort of 15 suggestions to enhance audit and feedback. And we were like, oh, we were doing this sort of stuff. We should write up what we've been up to. So the answer is yes, but there's a lot of variability. And one of the sort of series of suggestions is here. They talk about the delivery of the feedback, and I think, again, this has been a piece that's been missing from the dialogue around audit and feedback for a lot of years. So where's the data coming from? Is it from someone you respect? It's just like feedback for students. If the source of the feedback is incredible, they're not going to take the feedback. Although audit and feedback is a powerful tool for changing physician performance, it's not a panacea. The outcomes are variable. Some of the effects are negative, which we just touched on this morning. Sometimes they're powerfully positive, and they can change physician behaviors. And we presume that when we change physician behaviors, we sometimes actually improve patient outcomes. So I think the feedback was a piece of the thing that was going well in that session. It's also the receptivity and the culture of the group. But we know from educational sciences all these different elements and many more, this is just a summary of my favorites, are important for feedback. So to make feedback uptake occur, we think these things are valuable. So in-person delivery, credible data source, actionability, social interaction, that's from a social learning theory from the 60s, Bandura, maybe even 50s. Educational alliance, how many people have heard of the Educational Alliance? How many people have heard of a therapeutic alliance? So most people know, that's the idea that psychologists had, that if they were going to make progress with their patients, they had to have an effective partnership with them. And the idea of a therapeutic alliance in psychology is that it's actually determined not by the psychologist, but by the patient. And so if you trust that that person has your best interests at heart, and you believe what they say, and what they're saying is based on things that you know to be true, then there's a therapeutic alliance. And Glenn Regier and Dr. Telio put this idea together in the context of education. So I'm much more likely to believe your feedback if I trust you, and I think that you're here to help me be better. And I know that what you're telling me is based on something real. Either you saw me do it, or we have hard data. So that's quite relevant to the work we're doing.